Yeah.
So we shall now go on to our next young dynamic surgeon, Dr. Vini Joshi, who's a consultant ophthalmologist specialized in cornea and anterior segment and cataract from LV Prasad, Hyderabad. So on to you, Dr. VINEET. Let's see your interesting case examples.
Thank you, Dr. Chitra. Thank you for giving me this opportunity. Thank you, AIOS, ARC, and a very good afternoon to our expert panels. Is my video screen seen right now?
Yeah.
Okay, so just to add to the points which were discussed earlier about IOL opacification, the great points put forth by Dr. Om Prakash, Dr. Rajan, and I think I'm just going to show you a similar case where I did what you were suggesting. And so this was a case 4 years back. We had an IOL opacification, again a hydrophilic lens. Now you can see here, this was exactly what Dr. Rajan was saying, that the optics is separated from the back, but the haptics are fused densely. And I was trying to get around it, but if you see, I was trying to pull it out, it was penting the bag and it would have come out in toto, which I didn't want to do in this case. As the patient had a vision of 2120 improving to 2080, I thought if we could do it in a more atraumatic way and preserve the bag and put just an IOL, we can do it. So I went ahead with the IOL cutting scissor and tried to separate the haptics from the optic. The problem was to dissect it from the upper side because the angle was a bit difficult from the superior incision, but still with the help of Sinsky with an using it as an anchor or leverage, I kind of elevated it and then got a plane to dissect it fully and then put visco under it. So then it started to float in a plane which is comfortable to operate. Once that was done, then I took a micro forceps from the other side to kind of bring it, level it out, and then get an way to cut to this proximal end. After this was done, I floated the whole optic into the anterior segment. It was quite large, so had to divide it diagonally so that the two pieces can come out through the clear corneal incision without extending it. So that was possible. And after doing that, you can see there was still a little remnant of that optic there, which also then it was easy to chip it off with the scissor. Some part I tried to do it with micro scissor, but I would tell you to avoid this because it flips, as you can see here. So scissor is the best. Then I took a 3-piece IOL, and this time I put the haptics in the opposite diagonal quadrant so that they don't overlap the previous haptics of the lens. And the lens fit well in the sulcus without any issue. So that went well. And the patient did well. At 1 week, the vision improved to 2020. And she was happy with the quality of vision. So that was one. I was just going to share three videos which I operated in the last few months. And I thought I'll just get all of these in a short sequence. The next is doing cataract surgery in a very hazy cornea where we had planned to do DSEC as well. What I wanted to highlight here is how quickly the cornea becomes so hazy, especially when you're doing it in a case where there is already a existing PBK. Now you can see the central area which is hazy here, and when you remove the epithelium, it bleeds, and after some point of time, it starts to become hazy from both the sides, from the epithelial side and the endothelial side as well. So what I felt here is after doing trench, I couldn't see anything at all. And the last thing that you want in such cases is the rent, because that will complicate all the scenarios that will come forward. So the best thing what I felt was to just prolapse the nucleus in the anterior chamber, because anyways you're going to do a DSEC. So break it into pieces and get it out here. What really helped here was doing hydrodelineation, because that golden ring which shines, that gives you the contrast that yes, somewhere you can see the nucleus and you're eating it and not anything else. So my heart was pounding at this particular step because nothing was clear until the cortex was aspirated fully and I could see a red glow. But you can see the amount of whiteness and the haziness in the cornea which increased. If you just see a few minutes back, it was not that much. So it is very tricky. And at all costs try and avoid, like I tried to avoid a PC rent, and luckily it was successful, and I proceeded with desmetorexis and DSEC after that, and it went well. The last case is in a traumatic case, post corneal tear repair, small tear, with 3 sutures only. We removed that 1 suture. But what happened was he developed a traumatic cataract. Ideally, in traumatic cataracts, we just aspirate loose lens matter at the first visit and don't touch the bag. But in this case, I think the lens matter was so loose that it had to be aspirated fully. What it led to is that the anterior capsule had a rip and it was fused with the posterior capsule. Now, this was a unique challenge. So I had to separate the anterior capsule from the posterior capsule and make a customized rexis with a forceps. So half on one side and half on the other side. But on at 6 o'clock, you can see here, there was a kind of, we can't say it is a posterior synechia, but it was a fibrosed anterior capsule. So I just divided it with cystitome and made some space to kind of convert it into a half rexis on one side and avoid touching in that fibrous region because that's where it would have gone to PCR. Luckily for this patient that it did not involve the posterior capsule at any point of time and we could get 2 half rexis in place and so what I could do is I could place the IOL horizontally in this patient which was stable and the patient did pretty well and luckily for him the tear the scar of the tear was not in the visual axis so he was seeing 2025 by 1 week. So that was it. Thank you.
Very terrific videos, Dr. Vineet, one to beat the other, and a lot of very relevant take-home pearls in this. I mean, there is, you have told us everything about the IOL opacification, and this was very well discussed. So I'm not going to go into the challenges of that. But what I would want to ask you here is, when would you think of doing a sequential surgery or a combined surgery with a cornea and a cataract surgery is concerned?
Sequential surgery in doing in EK triple is a bit challenging because especially you'll have to wait for a long period of time. Now, if you're already seeing that if the cataract has developed, might as well buy the time for the graft to survive because doing a second surgery is again going to cause endothelial cell loss later on. But sequential surgery you can do in some cases of DMEC in Fuchs endothelial cell dystrophy where the cataract changes have not started as much. And it is well documented that if the natural lens is still doing fine, the visual outcomes are much superior. Like the visual recovery is very fast for those patients. So yes, mostly I would err on the side of triple procedure if possible. But in such challenging cases, very difficult to do. Whenever the cornea becomes hazy, I think maybe I could have used an endo illuminator or something, but in that point of time, I was a bit anxious.
Yes, endo illuminator could have been used. My only concern is situations wherein if the cataract is not as it was, you know, IOL power calculations become a challenge in some of these eyes. So if you are do it in a sequential manner, maybe it could have helped. But each of your cases were beautifully dealt. I want any of the expert panel to participate and ask question. Dr. Kapil Vora, would you want to add something here?
For the first case, you know, which we did, it was perfectly done. I would have used an AC maintainer, you know, to give support, to have an inflated big bag all the time. Because, you know, with the amount of manipulations being done, you being a cornea person would have been wary of, you know, corneal endothelial trauma. So I would have used, you know, an AC maintainer along with to, you know, give further protection to the corneal endothelium.
Yeah, that's a wonderful thought. And of course, endo illuminator probably, but you did it very well, superbly well.
Very nice videos. Can I say something, Chitra?
Yes, yes.
Okay, as far as the first case is concerned, see, the second case is beyond my capabilities. I won't comment on that.
Yeah.
As far as the first case is concerned, we have a series of our own because, as Dr. Mohan Rajan said, there was a particular kind of IOL which used to turn opaque after 2 to 3 years. And it is actually very difficult to separate out the haptics if they are Rayner type. And if you have the 4-point haptics, it's slightly easier to separate them out and you can get an intact bag. But most of the times when we got these cases, already a good opaque posterior yak capsulotomy had been done by the surgeon. So the problem arises from there. Although this capsulorhexis is also fibrosed by the time the patient comes to you, but most of the times when you're trying to pull out the haptic, this spreads and you don't have any bag left. So what we have done now is that, yes, we do try to separate it out if there's a capsulotomy, but if it is, badly fused, like in your case, we pull out the whole bag, do an anterior vitrectomy, and now we have very good methods of scleral fixations, and we resort to that. This is what I would like.
Yes, yes. There are different ways by which you.
One point I would like to add, Chitra. We need very nice videos. Only thing is, while cutting the haptic optic junction, the first case, the opacified
Yes.
I would always hold the optic because I need to have some grip there, some sort of resistance. I hold the haptic with the micro, that is a lens holding forceps. Okay, hold the haptic so that you will now have better grip while cutting because you will not without giving traction on the bag. That is also very important to cut. So you want to make sure that there's no traction on the bag as well.
Yes.
Yes.
Thank you very much, Dr.
Very nice.
Vini.
Very important
Wonderful
points, yes.
videos. You do stay on with us and add your comments along.